for the opportunity to present. I'm Ivo Petrov, presenting on behalf of Dr. Stankov. My disclosures. Despite peripheral artery disease is not widely recognized as a disabling condition, it has become an important indicator for generalized atherosclerosis and a strong predictor of future myocardial infarction and stroke. And probably this is the reason the screening for PAD entered both in the European and the American guidelines. Unfortunately, the methods of this screening are not very precise. Like one of the classic is the pulse palpation. We know very well that it's operator dependent, it's not the precise method to show peripheral arterial disease. The golden standard, the ABI index, in some patients, especially in diabetics and very calcific lesions, is neither the perfect tool. It can give wrong information in up to 50% of these patients. So what do we need to early recognize peripheral arterial disease as a screening method? The method has to be non-invasive, safe, no radiation, no contrast, quick and reliable, non-operator dependent, no physical contact, and if possible, cheap. And the answer is this: infrared thermography, temporary. I will remind you the saying of Hippocrates, the sentence that he said, should one part of the body be colder or hotter than the other, disease is present in this part. So this is the idea. In fact, the history of infrared thermography is starting with William Herschel, who discovered the infrared radiation and its application in astronomy. The medical application started in the 50s of the last century, and after a huge gap, now after the COVID pandemic, the interest rose tremendously. And the combination of high resolution thermography and artificial intelligence, like in Kelvin Health application, has led to really better application of infrared thermography. Several small publications have proven as a screening tool compared to the ankle brachial index, the infrared thermography, like in this publication, and also as a good handy tool for follow-up in patients after endovascular and surgical intervention. And especially in diabetics, we know very well that the diabetes is a pandemic situation, non-infectious, but between 10 and 20% of these patients are unfortunately with peripheral artery diseases. Screening is very, very important. How the procedure is done is very simple. In the same position of the object, same surrounding, at ambiental temperature, taking the picture at a distance of 60 to 70 centimeters. And after generation the pictures, in fact, the artificial intelligence is making post-processing analysis and segmentation in order to reduce artifacts and to have better visualization of the segments. In our initial experience of 42 patients, compared to ankle brachial index and angiography, the sensitivity between 81 and 100% was shown in different segments of the peripheral artery circulation. You can guess what is the underlying condition in this gentleman. The underlying condition is infrarenal occlusion of the aorta, Lewis syndrome. In this female patient with iatrogenic occlusion of the brachial artery, you see that the fingers of the right hand are in a deep tissue ischemia, and on the right side is after correction of the occlusion. This critical limb ischemia on the left side on the right leg was corrected, and on the right side of the screen is the tissue perfusion. In this case, I'm showing a type B aortic dissection in a young 53-year-old male, treated on the classical way, two overlapping stent grafts and one bare stent below. And the left femoral was closed with the Manta closure device. During the night, the patient complained with uncontrollable pain of the left leg, and the young colleague on duty took a picture, an infrared picture, and sent it to me. More than obvious, on the